Good morning, everyone. I am Martie van der Walt. I'm from the tuberculosis platform of the South African Medical Research Council. Today is the first of our series of 3 webinars where we look at the paradigm shift in facility management in the COVID era. My co-host is Pieter de Jager. Pieter is a registered architect and currently research group leader for infrastructure innovation in smart places at the CSIR. Pieter's interest is in the application of science, technology, and an evidence-based response to improving the performance of the built environment, such as infection prevention and control. I want to say a special word of welcome to our panelists. We are looking forward to their presentations, very informative, and then also to all the other participants who dialed in this morning. For some, it would already be evening or afternoon, and indeed very early in the morning, but we trust that you enjoy the webinar as much as we have through putting together. Before we start with the presentations, we want to reflect a moment on the work that the late Professor Anton Stolz of the University of Pretoria contributed to the infection and prevention of tuberculosis in the built environment. Anton Stolz passed away on 20 May 2020, and he was an advocate and a lead scientist in understanding the environmental prevention measures in the built environment of tuberculosis, as well as the role of personal protective measures, specifically the wearing of face masks. Upper room germicidal ultraviolet irradiation, together with air mixing, has been shown to be highly effective, but improved evidence was needed on the dosing guidelines to make certain that these devices perform optimally. The work that Anton has been involved, together with the MRC, CSIR, CDC of the USA, and Harvard University, showed that UVGI, together with air mixing, was highly effective in reducing tuberculosis transmission under hospital ward conditions. And these data also provided information on the optimal dosing schedules of the devices and the luminaires. Other work that Anton Stolz was involved with showed that the wearing of face masks by patients in a tuberculosis ward reduced significantly the transmission of their TB organisms to the environment, and this showed that the wearing of surgical masks reduced the transmission by patients if they wear it in congregated settings. Now, without further ado, I give over to my co-host, Pieter de Jager. Thank you, Pieter.
Morning, everybody, and welcome to this webinar. It gives me great pleasure to welcome a really wonderful set of speakers today. The first of which is Professor Adriano Dozé, who's a professor and head of clinical microbiology and infectious diseases, as well as director of infection prevention and control laboratory and unit, jointly with NHLS and the Wits School of Pathology. Adriano.
Well, good morning, everybody, and it is a great pleasure to take part in this webinar. My job has really been to set the scene, I beg your pardon. I'm busy setting the screen as well as we speak. And I think it's really important that we try and understand something about coronavirus very briefly. So can you all see the screen? Everybody can see that?
No, not seeing your screen, Prof.
I beg your pardon. So let me just see what has gone. It was all working perfectly well earlier, but things do sometimes do strange things. There we go. I think you should be able to see the screen now. Yeah. Okay. So COVID.
It seems to be on it. Perfect.
Yeah, I'm happy. Yeah, thank you. COVID-19 in the workplace is really the title given to this talk to set the scene. So coronaviruses have historically been relatively innocuous organisms, well known for causing infections in animals, respiratory infections, but others too, and in fact an important cause of the common cold in human beings. And the last decade really saw the emergence of, in fact, really the last maybe 10, 15 years, the emergence of coronaviruses that have been particularly pathogenic to man. And we will all recall the drama that SARS-CoV-1 caused in 2003. That did not reach pandemic levels, but it certainly actually involved a huge area of Asia. We then had, in fact, MERS coronavirus emerging more or less around about 2012-13, and now we are dealing with SARS-CoV-2. These single-stranded RNA viruses are exceptionally delicate viruses. They're surrounded by a lipid membrane, which means that disruption of that lipid membrane with surfactant-containing materials, such as soaps, or anything else, the detergent type of activity is very effective to get rid of these viruses. So you do not need complicated strategies to get rid of them, and this is important when you think about what needs to be done in the workplace. They're called corona because under the electron microscope, they look like the crown of a medieval king with very specific spikes on the crown that gives it the name corona. These viruses have bats as a natural reservoir, and there are intermediate vectors, which are usually mammalian, and a lot of initial contact transmission may occur when there is contact between, in fact, a non-human mammal, particularly in wild markets, as we've already heard of in Wuhan City, and that contact really actually becomes translated into human infection. The problem with coronavirus is that they're highly efficient at recombining, and mutations make the virus very adaptable to infect new hosts and species. So humans are very prone to infections, and newly adapted and new genetically distinct viruses, such as SARS coronavirus 2, are really posing an important challenge in terms of what you're seeing right now. Not only a huge pandemic causing a huge amount of morbidity and also associated with a distinctly unpleasantly large number of deaths of vulnerable populations, but also in fact a virus that leaves in its wake social, political, economic devastation. And certainly in the short-term future for many people, the prospects are rather bleak, largely because there has been job losses, etc. And there's also been, to a large extent, fear and a sense of hopelessness amongst populations. SARS-CoV-2 couldn't have really actually been present on this planet without the perfect synchronization of events that really led to it to be the pandemic giant that it is now. So firstly, there was, in fact, a described animal-human interface connection or a contact transmission, and animal-to-human transmissions are called zoonotic transmissions. And when, with adaptive gene recombinations, etc., the virus became exceptionally well adapted to a new host. The world has got a lot of elderly people. This is very typically important in Western Europe and certainly in the north of Italy, where I come from. But they're also, in fact, vulnerable population in terms of pregnant females, patients with underlying immunosuppression, and a variety of underlying medical conditions that seem to be, in fact, risk factors for acquisition of not only disease, but rather severe disease and even death of the virus. The efficient person-to-person spread of this novel agent means that there has been, in fact, very high transmission, largely because there's huge population mobility, and also all kinds of voluntary and involuntary behaviors that drive transmission that we will be looking at a little bit later. again, the whole world, to try and launch a fully fledged, coordinated global response has been caught, if you like, with its pants down. And trying to bring multiple stakeholders to give correct messaging, which is uniform, has been exceptionally difficult, and also a challenge in many respects to get the outbreak under control. And of course, there has been poor public health and laboratory capacity, particularly in parts of Africa, and even all over the world. Nobody was prepared for a respiratory pathogen that could have such a dramatic impact. And so PPE stockouts rapidly occurred, insufficient bed facilities, lack of ventilators, etc., all became in fact a problem. And all of these factors synergizing together have given rise to a very complex outbreak with, again, not simply complex morbidities and mortalities and novel manifestations of disease and pathogenesis, but also, in fact, with a lot of societal, political, and economic fracturing. So there are all kinds of ways in which you can get numbers for COVID cases globally. This is one of them. The absolute numbers that I'm showing you now really do not matter, because in 2 hours' time they will be different. But in excess of 10 million cases of coronavirus disease have been described globally, resulting in excess of 500,000 deaths. In South Africa, we are well into the 160,000s, and the mortality rate is slowly approaching 3,000. What is very interesting in this kind of graphic is that it's not as simple as it seems. Remember, there has been increased testing capacity, which will result in increased number of cases being found, and in addition, obviously, increased detection, giving rise to patients going into hospital and increased numbers of death. But I want you to forget about the testing aspect, which is critical, by the way, in these graphs, and just look at the sense that these two charts are showing of what is happening as, in fact, each lockdown level is lifted. I'm not sure what is happening in your spaces, but in my community, level 3 seems to have been a free-for-all for people, especially young people, who have become rebellious against wearing masks. They are quite aggressive sometimes in the workspace, thinking that they do not have to continue with things like social distancing. And I fear that all of these things are going to actually severely propel the outbreak curve. And this anger against infection prevention control, anger at social distancing, anger at lockdowns, anger at having to wear masks is a remarkably dangerous event that is becoming more and more rife, and that will need to be looked at. From a transmission perspective, the virus is mainly spread by the droplet and contact routes. There is no doubt that if you create mechanical aerosols, the virus can be acquired by mechanical aerosolization. This is a very typical phenomenon that would occur, for example, in a medical facility when a process called induction of sputum is carried out, or in fact when patients are resuscitated or ventilated. Aerosol generation during kinds of those procedures containing virus are important events. So in the healthcare system, we always say that you do not need anything other than a surgical mask, generally before most activities, and it is, if it's of good quality, very protective, and will do what it needs to do in the COVID outbreak. But we would still push N95 or FFP2, FFP3 equivalents in for any procedure that will result in aerosol generation in our medical units. And then there's an interesting notion of the fecal-oral spread of this organism that I'll go into very shortly. Now, transmission is always a complex event, and it depends on a number of factors. It depends on the virus and it's the amount of virus that is present in secretions and or contaminating environment. This is known as so-called infectious inoculum. It's dependent on the length of exposure, the type of exposure a person has had, host susceptibility, ventilation, was there any possibility for a dilutional effect of air to come in, and also whether infection prevention and control measures were in place at the time of those exposures. The main routes remain primarily respiratory droplets and contact routes, which means that social distancing is the order of the day. and you want to try and keep as far as possible from an individual, spacing yourself within a 1 to 2 meter distance. And you also want to actually continuously wash your hands to remove any organisms that are picked up from, for example, contaminated surfaces and brought directly to the conjunctiva of your eyes or your nose when people touch their face. This means that in the work environment, all niceties, and certainly in all environments, such as handshaking, are not allowed. And if you do the elbow greeting shown by President Ramaphosa, that is not on. It immediately puts you within the 1 to 2 meters of social distance that should be applying. So the greetings need to be different, and it's not business as usual. We need to behave differently until in fact, we see some light at the end of the tunnel with COVID-19. And I've already touched on the importance of aerosols. Now, in terms of transmission, when people ask us, we think on the basis of data that the organism is spread in the airborne way, like TB, measles, and chickenpox. We need to understand certain things, that if it were true that the organism is primarily airborne spread, like TB, TB, chickenpox, and measles, then the epidemic curve would be very, very different. What you're seeing on average is a reproductive number, which is the number of cases that one infectious person generates, fluctuating in the South African outbreak anywhere between 1 to 2.5. And these fluctuations actually will continuously change, and the increases and decreases depend really on the efficacy of the outbreak response, on contact tracing, on finding infectious people, etc., protecting susceptibles. So you can see that if one patient infects 2 people, we'll just take it as a very simple number, then 2 people infect 4, and then in fact it spirals out pretty quickly out of control. So if we use, from an epidemiological perspective, the reproductive rate of an organism to try and gauge whether airborne transmission is really the danger, and this is what a lot of people in the social media are saying. You breathe the virus in, you go into a room and it's hanging in the air, and before you know it, you'll be infected. You can't get out of infection. If it were true that that were the case, then the reproductive number would be very different. So have a look at typically contact-borne infections, such as, for example, hepatitis B, Ebola, and yes, believe it or not, SARS, which was predominantly in 2003 found to be spread by contact, slightly more than respiratory droplets. Look at HIV, where one person in the life of that person's infection gives rise, in the absence of interventions, no ARVs, no pre-exposure prophylaxis, no antiretroviral treatment, etc. One individual gives rise to 4 other cases. Mumps, which comes after the respiratory droplets, where COVID is also a problem, it's spread by the contact-ridden droplets, in principle actually gives a reproductive number of 1 person give rise to 10 infectious cases. And we can see that COVID is actually nowhere near, in fact, the full potential of transmission as mumps is, in the absence of vaccines for mumps like the MMR. And then measles, TB, etc., and 1 person gives rise to many, many, many cases. And so it really fits best, COVID, as being spread, looking at epidemiological data and evidence, somewhere between the contact and the respiratory droplet route. Now, contact transmission is important, and what we don't understand is that frequently these contacts are when hands touch indirectly surfaces that are contaminated with soiled respiratory secretions. And there is evidence that the virus is able to be present or detected on various surfaces for different days. So on plastic for 5 days, on paper for 4 days, on glass, etc. So all of that is there for you to see. The problem is that a lot of these measurements look at the presence of viral RNA rather than necessarily the viability of virus on those surfaces. But let's assume that those are the timeframes on which viruses can can survive, just because we need to remind ourselves that it's always important to wipe down and decontaminate the personal workspace or area where one is working in. Virus can be present on computer keyboards, on cell phones, on elevator buttons and screens, on elevator, or rather, yeah, these elevator, these wheel turning elevator, or escalators is the word that I'm really looking for. Those rails of the escalators that are always moving. Virus is potentially present there. And there's a lot of evidence that infection, for example, of using other respiratory pathogens as a measure, influenza viruses, respiratory syncytial viruses, etc. These infections can be dramatically reduced by simple hand hygiene. And so one of the most important messages that must come out is that hand hygiene is critically important. Contaminated hands are often brought to touch the face and mouth, and the danger of touching your face is inoculation of virus into the eyes and nose and mouth. And it is important to remember that touching your face is an exceptionally common habit. Everybody, including one of you, will have touched your face probably several times during the course of these few slides. And it seems to be that, in fact, healthcare people who shouldn't be touching their faces do it more often than everybody else. Some measurements have actually seen that they usually touch the face as often as 50 times an hour, often to readjust PPE that is not comfortably fitting. So please, there is not just perform hand hygiene once a day or before eating or after eating or before going to the toilet or after going to the toilet, or wash your hands at every single opportunity. There is one of the speakers, Leslie Devonish, that decontaminates passengers on airplanes, because the minute she sits down, she saturates their seat in front and the little table, and she washes her hands because it's a new environment. And I think Leslie, every 10, 15 minutes, decontaminates her hands. That's the kind of thing that you should be doing with an alcohol-containing hand sanitizer, which has got an emollient to soften the skin. So contact transmission is important, and you're going to have a whole talk on hand hygiene from Leslie. When it comes to droplets, it's very tempting to always talk about droplets as being those droplets that are large and fall to the floor for various distances, and those droplet nuclei, tiny little droplets that are generated by an aerosol, as you can see here, which almost must desiccate quickly and remain suspended in air for longer periods of time. That temptation of categorizing droplets as falling an X number of distance and droplets that are a bit larger falling another X number of distance, and those that are tiny and evaporate remaining suspended, is somewhat artificial, because what we really need to understand is that in every expectoration that occurs, whether you're sneezing, coughing, or laughing, you get droplets that form a continuum of those that are very large and those that are very small. We believe, on the basis of the epidemiology and the current evidence, that COVID is spread predominantly by large droplets that are generated when speaking, when coughing, etc., that travel up to distances of 1 to 2 meters. So if there is that movement of droplets, that's a kind of social distance and spacing that one would advocate. In the SARS outbreak of 2003, some people then suggested 3 meters, because sometimes these large droplets can be, on the force of expectoration, made to travel further. But the metric that usually is used by the Department of Health is 1 to 2 meters. Is there any evidence that this works? Well, in social distancing studies, and this was published in The Lancet, by simply removing yourself from a potential source by 1 meter, you can reduce more than 80% of transmissions. So that is a good punt for social distancing, which is important. And then what's in a toilet? Well, this is a different way of getting into contact or aerosolizing organisms. When you actually flush a toilet, plumes are created, and material from this plume can land up on, obviously, the mucous membranes of the eyes, on your hands, and in your nose. These droplets and these plumes can contaminate the toilet area for up to 1 and even a bit more than 1 point something of a meter. And so it's exceptionally important for you to actually close the lid in the workplace when you flush toilets. And because you never really know what nasty little critter is sitting in those bioaerosols. Now, within the context of the SARS outbreak, toilets indeed and toilet plumes are very important. There was a gentleman who lived in a very, very upmarket estate. It was a set of residences called Amway Gardens. He occupied a flat on the 16th floor in a particular block of that flat. And as a consequence of faulty plumbing and formation of plumes, contamination of air ducting, this gentleman's flat was the source of an outbreak. And what basically happened is that the gentleman's brother was a renal transplant patient. He always went to the nearby hospital in Shenzhen, which was an academic hospital, to be followed up. And after his visit, he would always go and have coffee with his brother in this flat in Amway Gardens. And whilst going in and out the brother of hospital, he acquired, in fact, SARS coronavirus in 2003. He had a bout of diarrhea, and he used the toilet. There was, in fact, defective plumbing that was confirmed. And all of a sudden, in fact, he singly, in one super spreading event, which was mechanically aerosol generated, was allegedly responsible for 321 SARS cases. Now, whilst you return to work, it's important to remember that there's a lot of things that you can do to reduce risk. The first important thing is, please, it's not to reduce COVID risk, but to reduce, in fact, absenteeism in the workplace. Have an influenza shot. It gives you no protection against COVID-19. We know that it's not 100% effective. In fact, influenza virus vaccine strains, and usually put 3 or 4 of what are considered or predicted the most important circulating strains in a season, can have an efficacy of as low as 40%, right? But let's still actually start reducing 40 to 50% of people being absent with a respiratory infection and creating panic. Is it COVID or isn't it? That you're already actually making some headway in reducing potential problems in the workplace. Also remember that if people are resistant to get the vaccine because they say it doesn't work, vaccinees, if they get influenza, develop less severe disease. And also, if it's complicated disease, they are linked to reduced deaths, reduced infectious intensive care admissions, and overall they do better than those that have not been vaccinated. There are many influenza strains at any point in time. By the way, 3 to 4 of the most important ones are the ones that are selected in vaccines. It does not mean that you can't get influenza from others, although there is evidence of some cross-protection between the various influenza viral strains that are circulating. Please also remember that in South Africa, with immunocompromised patients, not everything that is a respiratory infection is necessarily going to be COVID-19 disease. We are right now in our influenza season. June, July starts around about May, and the winter months are the ones where we start getting a lot of transmission. So influenza is definitely an important confounder. There are lots of other circulating viruses, non-COVID-19 coronaviruses causing colds, rhinoviruses causing upper respiratory tract infections and upper respiratory tract infections, and respiratory syncytial viruses causing, in fact, respiratory infections of the entire respiratory tract. Pneumocystis is always a problem in HIV individuals, and the bacterial pneumonias in the elderly, which are vaccine preventable, like pneumococcal disease, must be remembered. For those of you that may have gone back to building that was standing during the lockdown, you need to consider that also the health of that building is actually quite important. Was it safe for occupation? Did you test that building for Legionnaire's disease? The agent of Legionnaire's disease, Legionella pneumophila, because for the record, that can be 10 times more lethal than COVID-19. And I'm not quite sure how many people are checking the workplace for Legionella presence in the hot water systems, plumbing, HVAC systems, etc. Now, going back to work, also people must remember that employers and employees are governed by a legislative framework that clearly sets out responsibilities of the employer and responsibilities of the employee. And to notice that the employer has got an obligation to educate, to conduct risk assessments, making sure the environment that the people return back to is safe. There should be safety procedures, safety officers in every workplace. There should be training, and there should be provision of reasonable types of things. For example, the NHS gives, but this is a health institution, 2 masks every day to their staff. They're not necessarily the greatest of masks, but at least they get some masks, and 2 cloth masks for them to use, and orders provide sanitizers, etc. Staff screening is important. Screening actually looking at exposure, looking at temperature, and looking at symptoms, just adds a layer or 2 extra of potential of protection. It does not eliminate cases or pick up all the cases with COVID disease. So all we're doing with social distancing, with masks, with all of these things, is adding additional layers of protection, and we'll be told how to do those shortly. Responsibilities of the employee are also critically important. The employee has got a duty to comply with anything that is put in place in the workplace for the safety of that employee. And so there are really responsibilities on the part of both employer and the employee. In infection control, we have hierarchy of controls. I'm not going to read a slide because it's very boring, but hierarchy of control involves administrative things where you can actually obviously do risk assessments on the workplace. You have to have a strategy to deal with vulnerable staff, educate, provide a safe environment, provide appropriate signage, make sure that people are transported in and out of the workplace safely, wherever that is possible, make sure that social distancing is maintained, have leave policies, and above all, please go towards greater flexibility rather than greater rigidity. Engineering controls, the role of ventilation is going to be spoken to by Tobias van Reunen. I've seen his talk and it's outstanding. And reconfiguring the environment spatially is also something that could be part of the engineering controls. And then it comes to personal protective equipment and related issues of keeping the workplace safe. Leslie Devonish is going to cover that. So there are some policies that I won't go into because they're about to change. And these are guidelines that people in the workplace need to know about what needs to happen if you identify a COVID positive employee and what the management would be of a either suspected or confirmed COVID-19 case in the workplace, as well as guidance and on routine and deep cleaning workplaces, or deep cleaning of workplaces when COVID is suspected. So all of these documents here in the last slides are undergoing change as we speak. I want you to simply be aware of that legislation. I want you to look out for new regulations because it will help you actually judge when somebody should return to work, whether PCRs after 7 days are of any use or after 14 days. All of that is going to be much more clarified so that people have got clear-cut guidance. But that is not officially available. So what I've shown you here is what is present at the moment. So with this, I'd like to hand over to Leslie, who will then start talking about, in fact, keeping the workspace safe. Thank you.
Thank you so much for that excellent talk. I hope that you will remain with us because we're going to have a question and answer session at the end of all presentations today. If you have got questions and you're listening in, please type them in the chat box and we will come to it. I'd like to then introduce our second speaker, Leslie Devonish. Leslie is Infection Prevention and Control Project Coordinator at the Department of Clinical Microbiology and Infectious Diseases, also with the National Health Laboratory and with the University of Witwatersrand. Well, welcome, Leslie, if you can bring up your presentation.
Thank you, Peter. Thanks for the introduction and thank you for the invitation. So I'd like to touch on very briefly the major ways of keeping your workspace safe. And trying to get my slide to move to the next slide. Okay, great. I don't know if everyone can see that. So an easy way to remember the most important things to keep your workspace safe are the 4 W's, which stand for wash your hands, wear your mask, watch your distance, wipe your surfaces, and we can add another one, windows, keep them open. Let me start with hand washing. Hand washing is well proven to be the most effective way to prevent transmitting infections to yourself and to other people. It's very important in the workplace to have notices up for the methodology of hand washing. This kind of notice in a non-medical setting is perfectly okay. One must make a point that cuts on hands should be covered before hand washing. In winter, especially when our skin is dry, to wet hands before applying soap, to rub the soap into the hands for at least 20 seconds. And the reason for that is your skin is not completely smooth as a table surface is smooth. You have ridges and nooks and crannies in the skin where the bacteria hide. And you need to wash and rub that soap into the skin for it to be effective. To rinse well, and then to dry the hands, preferably on paper towel. So if employers can concentrate on providing additional stock of paper towels for people to dry their hands so that they're not tempted to dry hands on clothing, that would be great. And then at every single basin in the workspace, there should be a poster with the methodology of hand hygiene. So the next slide shows you the medical hand wash, which is not a bad idea for people to practice in the community either. So it starts with wetting hands and taking soap, rubbing the hands palm to palm, then cleaning the backs of the hands, the tips of the fingers, the thumbs. So these are all the spaces on the hands where we touch things, the most common places on our hands that we use for touching objects. So if the employers could put in a poster up at every hand wash basin, that would certainly help people to practice correct hand washing. Then the next important thing is to wear a mask correctly. Masks work by helping to reduce the droplets which contain the virus from being released when you breathe, speak, cough, sing, etc. And the masks also lower the chance of droplets entering into your mouth and nose if they are worn correctly. And the next slide will show you some incorrect wearing of masks. The cotton masks that we wear in the community preferably should be made of 100% cotton because the spaces between the fibers of the mask are smaller, and so will keep out the viruses more effectively. Surgical masks do have 3 layers, so they provide greater protection, but obviously we need that kind of stock in our hospitals. Although many manufacturers are making surgical masks available in the community. To wear a mask correctly, to put on a mask correctly, one should wash hands, very important. Then place the mask over your mouth and your nose. It should cover the bridge of your nose and it should end underneath your chin. Important not to touch the mask while it's on your face, particularly the front of the mask, and don't take it off to talk to people or to cough or sneeze. To remove your mask, very important again to wash hands or use alcohol hand rub, and then to remove the mask by the straps and then throw it away immediately or put it into the wash. You can put it into a bowl of boiling water and then let the boiling water cool. That will also kill the virus. And then to wash your hands after you've handled the mask. This is a poster that you can put up of Things not to do when you're wearing a mask. I've circled a couple of them. People don't wear the mask above their nose. Their noses stick out. When they're wearing a mask, that you might as well not wear it, because then you're breathing out bacteria and viruses into the environment. When you want to talk or drink or eat, please don't put the mask underneath your chin. You're exposing yourself to all the virus that's collected on the outside of the mask. And then the third circle, don't touch the front of the mask. So there are many other do nots, and this kind of poster is useful. On the right-hand side, the picture of the lady with about 15 masks on, really not necessary to take that amount of precautions. And then the gentleman in the lower right who's kind of lost the plot and using the mask for a purpose for which it was not designed. So changing a mask, how often do you need to change your mask? Well, the more you talk, the quicker the mask becomes saturated with your breathed out moisture vapor, and the sooner it needs to be changed. So although we might have a rule that you could wear a surgical mask for 4 hours, for example, it really depends on how much talking you're doing. The medical mask has 3 layers, and the WHO says you can wear a medical mask for 4 to 6 hours. But as I said, if it becomes saturated, you need to change it more frequently. Some of the masks cause problems, hurt our ears when they're worn for a long period of time, and there are various ways that you can keep the mask on your face comfortably. On the bottom left, there's a very large paper clip being used to hold the loops behind the head. And on the right, this lady has crocheted or knitted herself a little band with buttons where she can hook the loops of the mask. So PPE in the medical world stands for personal protective equipment. But I'd like to suggest that we think of PPE as please protect everyone by wearing your PPE correctly. Then I want to talk about the social distancing, watch your distance. So the places where most transmission will happen is in places where we remove our masks and we are together. The left-hand picture is a picture of a tea room, and they said, well, it's fine, we've just told people not to use the chair in between. They can sit in every second chair. One chair's diameter or length, width, is about 50 centimeters. It's certainly not the 2 meters that you need for distancing in a tea room. And then the other thing is people move chairs to go and sit next to their friends in the tea room. So I would really suggest that employers look at their tea rooms and place tables 2 meters apart, have one chair only at each table, and remove the other chairs. And then put up a notice which very clearly says no more than however many you can fit in at a 2 meter distance, no more than that number of people at a time. Maintain the distance of at least 2 meters between people when you don't have a mask on, only one person at a table. Use hand sanitizer on entering and before touching the kettle or the microwave or any other common touch equipment. And then clean your chair and table after use or before use, whatever the rule is. Hand sanitizer should be available outside tea rooms and inside at the commonly touched appliances. And then provide plastic hooks to hang up masks outside or inside the tea room. And don't put, as in this picture shown on the right, don't put the hooks too close together, because then the masks will touch. And then people can mark their own mask with their name. The environmental cleaning, just one point, you cannot disinfect an environment without cleaning. So the cleaning is the first step. You need to clean with soap and water and then use disinfectant to disinfect the surface. So with the COVID pandemic, we need to do more frequent cleaning and disinfection. This can be achieved with wipes. There are wipes available. I don't have shares in Dettol, but Dettol wipes are well known in the community and are easily accessed. And then, as Prof mentioned about toilets need to be cleaned more frequently, and then we need to put up posters in the toilets saying to people, please shut the lid before flushing. I liked this. This was a company that made badges for their staff with a sign that said mind the gap, 2 meters, and it's just a visual reminder to people to please keep their distance if they're not wearing masks. Thank you.
Excellent. Thank you so much, Leslie. Don't forget to post your questions in the chat. There have been a couple of interesting suggestions also posted there, so keep an eye on the chat, but that was a very excellent overview. So now we've got an understanding of the epidemiological nature and the transmission dynamics of COVID. And we have some really good high-level suggestions on good strategies on how to deal with it. Now we're going to start to go into a bit more of a deep dive of interest to property managers, facility managers, and occupational health professionals. Starting with a speaker from the CSIR, my colleague Tobias van Rienen, who is a mechanical engineer by training, a clean room specialist, and who is very passionate about health and the built environment. Toby, if you could bring up your slides, please.
Give me a second, my computer didn't do what I expected it to do. I'll be here in a minute. Hopefully less than a minute. It's working in practice, I promise.
While Toby matters a little bit in the background, some of the questions that have been asked so far, all right, have been whether we will share these slides and whether the material can be shared, and we will make arrangements for that to happen. Toby, go ahead.
Morning, everyone. I trust you can hear me and not my neighbor grinding in the background. Unfortunately, there's nothing I can do about that. He needs to fix his gates. What I want to talk to you about today is largely ventilation and for what facility managers need to know and understand around a lot of the guidance they've been seen and are being given regarding ventilation primarily and back to work preparedness.
Sorry?
Relates to that.
Yeah. I finished talking, to stay on to
I mean,
the questions at the end.
The advice and the evidence behind the advice that we're seeing. There's essentially two things. Messages out there, apparently conflicting or contradictory, saying that we should use ventilation and others saying that we shouldn't be using air conditioning during COVID. I just want to dig into that a little bit. And then we're also going to dig into that a little bit and then talk about contingency operations, testing, maintenance, cleaning, and supplementary systems. Terminology always matters to make sure that we understand what we're saying. HVAC is commonly understood to be heating, ventilation, and air conditioning. Very little discrepancy there. The problems come down to the difference between ventilation and air conditioning. People don't think about them as being discrete or different elements of HVAC. Ventilation is the process where fresh air is introduced or removed from the space, in this instance, for the purpose of reducing indoor contaminant levels. Whereas the air conditioning is a mechanical process of cooling or heating your air to improve those comfort levels in that space. Prof. Duzay spoke about droplet transmission and airborne transmission, and it is a continuum. It is understood to be a continuum between the two, or you could even say airborne transmission is a form of droplet transmission. So just to reconfirm, droplet transmission in this context in which I'm going to talk about it is short range person-to-person or person-to-fomite transmissions through droplets which are generally too heavy to remain suspended in air indefinitely. Whereas when I speak about airborne transmission from a ventilation perspective, it's long range person-to-person respiratory transmission through the air. And it's the type of transmission that responds to ventilation interventions. whereas droplet transmission doesn't respond well to higher ventilation rates. So I will get into that a little bit. And then ASHRAE, for those that aren't familiar with ASHRAE, they're a US association for ventilation engineers, air conditioning engineers. REVA is the European equivalent of ASHRAE. And a lot of how I've just written into one of my slides. It's as low or high as reasonably achievable. And I've only used it because there wasn't enough space in my slide for the whole sentence. Just looking at some of the evidence. For evidence which talks about the impact on transmission of ventilation systems. And this is one of the, and this was an early outbreak that is often cited as evidence for airborne transmission. I don't think that's entirely correct. It's the, I might even pronounce that correctly, Guangzhou restaurant outbreak earlier this year. Patient 0 was sitting, it's actually labeled A1, sitting at table A in this restaurant, and patients, customers at tables A, B, and C contracted COVID from patient A1. And some comments on this study have said that this is evidence for airborne transmission. In true sense, yes, but the, if you look at the entire restaurant, below tables E and F, there were more tables, and only customers in tables B and C were infected. So if it was true airborne transmission, you might have seen it in more tables through the restaurant than just those directly adjacent to table A. And it's also interesting to note that tables E and F had no infections. And one of the probable reasons for that is the amount of time that the customers at table E and F were associated with table A was much shorter than B and C. They came in much later, and they didn't spend as much time with table A. So what I think we should take away from this outbreak study is not the fact that air conditioners spread COVID. It's that distancing matters. These tables are very tightly packed. It was 1 meter or less between the tables, and exposure time matters. So the tables, the people that spent the most of time next to patient 0 or close to patient 0 were most likely to be contaminated or infected. Okay, another interesting study was this outbreak in a South Korea call center. It's, was, I believe, a 19-story building. This was a call center on the 11th story. What you can learn from this is COVID-19 is exceptionally contagious in crowded office settings. The outbreak in this building followed the physical compartmentalization and not necessarily the HVAC zones. There wasn't much transmission seen between lobbies and lifts, and they resulted in limited spread. Sorry, give me 1 second, my dog wants to go out, just a second. Apologies for that. Okay. The lobbies and lifts resulted in limited spread. And again, with this, the exposure time correlated to transmission. So from these two studies, it's the amount of time you spend in close proximity without due protection or protections. Also some talk around aircraft transmission. Well, not some, there's been a lot of talk about transmission in aircraft. What we know about aircraft, well, SARS, there have been outbreaks of SARS and limited evidence for outbreaks of COVID on aircraft. But considering the amount of passenger hours spent in aircraft, this has been remarkably low. One of the reasons for that is possibly that aircraft cabins are typically ventilated at about 20 air changes per hour, which is very high. That's the sort of ventilation rates we find in operating theatres. And they have very high fresh air rates. About 50% of the air circulated through an aircraft is fresh air. SARS outbreaks, therefore they're rare, and they often relate to system failures. So what we've seen in a lot of the studies, you'll find that there was an outbreak because the ventilation system wasn't working, or because an aircraft was confined on the apron for a long period of time with power down. Those sort of events cause outbreaks of respiratory disease on aircraft typically. There are cases where patients were symptomatic and infectious that were contact traced from an aircraft, and no outbreak was found on that aircraft. So there is evidence, clear evidence that these environments can be quite safe, relatively safe, because of the high ventilation. Okay. Another study, it's often used to indicate the airborne nature of SARS-CoV-2. The airborne transmission of SARS-CoV-2 is this from Dumoulin report of the airborne stability of the virus. It states that 3-hour stability in air, if I remember correctly. The report, that study used a Goldberg drum to determine the stability in air. And they said that the virus survives for 3 hours in a Goldberg drum, suspended in a Goldberg drum. It's important to note that exactly the same equipment in a similar study was used to argue that Ebola was not, a new strain of Ebola was not airborne. So the 3-hour stability in a Goldberg drum doesn't mean that the virus is airborne and survives in the air for 3 hours. That study should only be understood to be that SARS-CoV-2 has an airborne stability similar to SARS-CoV-1 because they have similar survival times in the drum. Okay. So the question, and you can see where I've been leading with this, is should I still use my HVAC system? If your HVAC system in your building improves ventilation rates, yes, you must use it. If it's generally just a high wall split unit and you're going to insist that people keep their windows closed to run the air conditioning system, then probably not. So you need to increase your ventilation rates in these spaces to more than double the regulatory minimum per person ventilation rate, if it's possible. If that's not possible, you need to reduce the number of people in the building. Obviously, more outdoor air is better, and open windows then wherever possible and safe. Consider safety when you're opening windows. These are trying times. Opening windows in high buildings might be alluring to some, especially if there's small children and that in those spaces. Make sure that if you're opening windows that are not normally kept open, that it's still a safe environment for the occupants. Circulating fans improve ventilation effectiveness. So you might have a poorly performing ventilation system. You put circulating fans in there, you'll get better mixing in the space. So the amount of fresh air that you bring into that space is more effective. You want to prevent stagnant air in a space. But be careful, don't let your air conditioning units or your fans blow directly down or across groups of people, because that can increase the distance of droplet spread. So then your 1 meter or 1.5 meter distance might need to be 2 or 3 meters if you've got this direct continuous flow of air. Then also consider CO2 monitoring in your spaces. That's fresh air or demand control or economizer systems on your buildings. It's a good time if you don't have them in central air conditioning systems for larger buildings to consider bringing those kind of systems in. They can be retrofitted. REVA has a COVID-19 guide which recommends CO2 levels. Their specific guidance is 400 parts per million. I assume that they're meaning 400 parts per million above outdoor levels, because in many parts of Europe, 400 parts per million is below outdoor levels. So that's how I'm interpreting their guidance. That equates to about 16 liters per second per person, which is roughly double what is recommended for normal ventilation, office type ventilation. The CSR currently recommends CO2 levels of that should be greater than 200 parts per million above outdoor that is less than 200 parts per million above outdoor for TB, and this equates to about 32 liters per second per person. There has been some talk about controlling COVID-19 transmission by increasing temperature and RH. It's not feasible. It's basically as simple as that. To have any type of real impact, you're going to have temperatures of about 56 degrees Celsius and humidity is above 60%. You'll probably be killing people, not the virus. If you're going to, if you have a daily operation of the building, try to flush your buildings for about 2 hours before occupancy, and again about 2 hours after daily occupancy. And any exhaust systems, and Prof. Tusay spoke about.
Toby, we're getting feedback that you're not very great. Can you try and be more audible?
I'll speak closer to the mic. Does that help? So I'm going to continue. I spoke about flushing the buildings. Also, Prof. Tusay spoke about the risk in bathrooms and toilets. Those exhaust systems need to run 24/7. We don't want any of the air from our bathrooms to be leaking into our generally occupied spaces. Reduce recirculation on your systems if possible, as low as to levels as low as reasonably achievable for low-risk buildings. It's not an essential thing to do. If it can be done, try to do it. For high-risk buildings like healthcare buildings where you've got high aerosol generating procedures, no recirculation is appropriate. So, but for the most part, in South Africa anyway, that's how buildings are designed. So the position from the WHO and CDC and some of the engineering guidelines on face value seems to be different. The WHO says this disease is primarily droplet spread. It's close contact less than 1 meter. The CDC says talks about 6 feet, which is the same thing. It's spread by contact closer than 1 meter, so you should be keeping obviously greater distances between each other. And your controls are largely droplet precaution controls and hygiene and hand washing and so on. Whereas if you go look at the engineering controls, they seem to say something different. They say it is sufficiently likely airborne, and you need to introduce engineering controls to reduce exposure. So that's dilution, ventilation, reducing recirculation, and that sort of thing. And I think the difference comes between the way engineers and doctors think about airborne transmission. When an engineer thinks about airborne transmission, it's the type of transmission that can happen in a low-risk setting, a normal setting, through your ventilation system. So it can be drawn into your ventilation system, recirculated, and delivered to a different space served by that same system, which is not what we're seeing with COVID-19. So the risk of recirculation of this disease through a building with general ventilation does not appear to be a high risk. It's not the same story for high risk buildings where you've got high droplet generating procedures. Okay. So what do we do? If we're returning to a building that has been shut down for some time, I'm presuming most of the stuff is already in place. It should be part of your normal operation. But you need to make sure that your building is functional according to the original design criteria and is capable of meeting any new mitigation criteria that are required. For general buildings, there's not much of a change to the way you operate your building. You need to make sure that your components, such as boilers, chillers, and that start up correctly again, and that are started up according to the operation, to the specifications and the O&M and OEM manuals. You need to go and check that so those are your components. You need to check your systems as well start up correctly and are functional. That your HVAC systems, safety systems, and your plumbing. Plumbing, you need to do things like make sure that your traps are all full, that they haven't dried out, and that they, with the lower occupancy buildings, that they remain filled up. You might have to keep filling them manually. Make sure that you have commissioning reports on hand and testing balance reports to refer to the operating condition of those buildings. Also, review your building automation and reporting systems. Check that they're still functional online, that your set points are still what they should be, your alarms are working, trends and logs, etc. And then as it pertains to maintenance and cleaning, cleaning and maintenance is just as important as it's always been. I don't want to say it's more important because it should have been very important before we started. So it's still very important. But you need to catch up on any of your maintenance and cleaning backlogs that might have occurred during or before the backlog. Now's the time. I spoke about the traps, fill your drainage traps. Also test your water supply. If your water systems have been standing and stagnant, you might have some contamination in those systems. There are risks, Legionella risks and so on. Not a potable water risk, but if you've got water distribution systems where water can be atomized and breathed in, those need to be addressed. So go do tests of your water. Make sure that your water is safe for use or consumption. And then while we're on reduced staff contingent staff numbers, make sure that you have a contingency plan for technical staff. So you might want to consider cross-training some technical staff so that you have standing staff for emergency shortages. If one of your staff members becomes sick, you want to be able to continue servicing that building. Safety for your technical staff must be considered. Your air distribution equipment can be contaminated. All the evidence to date indicates that the contamination that has been found in ventilation systems and fans is nucleotide negative RNA. It's probably not viable, so the risk is very low, but it's nothing to wear a mask and a glove and when you're cleaning or dealing with this, just to keep yourself safe. So yeah, transmission risk is low, but standard personal protection precautions should be taken when cleaning or handling HVAC equipment. That should be PPE, I'll correct it when these slides are distributed. Leslie spoke about soap and water. We have been cleaning with soap and water, and we should continue to clean with soap and water. It is an acceptable cleaning agent for our systems. If disinfectants are not feasible, clean with soap and water. And for the most part, I'm not sure that cleaning out HVAC systems and ducting distribution systems with disinfectants is feasible. You need to continue with the regular cleaning of your blower coil or indoor units as usual. You should have been doing that anyway. You need to have biocide in your drip trays as usual. You should be doing that anyway. And then check the maintenance, check materials safety data sheets of your disinfectants if you're going to be using disinfectants. And as a rule, avoid generating chlorine, chloramine, or hypochlorous acid fumes in your ventilation systems. You don't want to be spreading chlorine fumes through your building. And then store, when you're removing filters or disposing of filters out of your ventilation system, especially the filters that are part of your recirculation air system or circuit, just keep those on hand, keep them in store for about a week before you dispose of them, just to allow any residual virus that might possibly be embedded in those filters to die out before they end up on a dump somewhere. I'm not recommending that we treat them as biohazardous waste. We're not dealing with these on medical facilities and the risks aren't that high. You might have been approached by vendors to install supplementary systems to improve your ventilation capacity and your the decontamination capabilities of your systems. There are things like portable air cleaners. You get HEPA filtered air cleaners and sorbent bed air cleaners. What I'm calling here canned UVGI. It's UVGI in a box with a fan. PCO, ozone, electrostatic systems, etc. Typically, these types of systems are not sufficiently effective to be feasible. They might be all right for domestic purposes if someone in the family suffers from allergies or that sort of thing. They generally aren't going to give you a significant enough boost in your ventilation capacity or ventilation effectiveness in commercial or industrial spaces or offices and spaces with a lot of people to make them worthwhile. If you're going to try that, you'll end up A, spending a lot of money, B, taking up a lot of space with these a lot of units, and C, they do make noise, so you'll be making a lot of noise. I wouldn't recommend going that way. UVGI comes in the form of upper room UVGI. Not really recommended for COVID-19. We would recommend that if you're trying to target airborne disease in the sense of TB or measles. It's not going to be that effective for the more direct type of transmission that we think about COVID-19 in terms of. If you've got biofouling UV in your HVAC system, or someone is trying to sell you a biofouling UV, those are the UV systems that clean your cooling coils. These aren't going to have sufficient dosage for COVID-19, so I would not recommend installing those. And you get return airstream UVGI, which is ducted UVGI. It sits in your ducting, very high power systems. They might be effective, but make sure that they are recommended by your risk profile and their risk mitigation only. They might not be necessary unless it's a very high risk environment. I'm not going to speak about transparent shields orientation. I think that's pretty different talk. So in summary, just 4 take-home points, and they are as valid now as they have been before. If you've got highly congested spaces, you need to decongest those indoor spaces because has the same effect as increasing your ventilation system. You need to ventilate as well as you can. Open windows, increase the fresh air as much as you can on your ventilation system, and reduce the return air as much as you can. You need to restore your systems to operate to their operating condition that you'd expect from them, and maintain them well. If there's a maintenance backlog, it's time to catch up on that. And then resist investing in miracle technologies where less than scrupulous vendors might be using this opportunity to push unproven technologies on you through strategies like scaremongering and that. So the impact might be not worth the investment. There's some references. You can go through them at your leisure. I've kept them to a minimum. It's really just CDC, ASHRAE, our local NICD, and REVA. Thank you.
Excellent. Thank you so much, Toby. And thank you for that. Now we're going into the question and answer portion. We have about 10 minutes or about just under 10 minutes for questions and answers. I've got 3 on the table so far, but please feel free to pop your questions into the Q&A. Especially for our earlier speakers, because most of the questions have been around HVAC and air conditioning. Okay, so the first question is actually for Marty, and the question was, are we going to be able to share these presentations, and then what would be the mechanism for doing that? perhaps you can answer that one.
Thank you, Peter, and thank you for that question. It shows that huge interest in yes, it will be posted on the MRC website. Afterwards, I have a slide to that's MRC website address. And we will also afterwards send out again an invitation for the next webinar, and then also link to where today's presentation questions and answers will be posted on. Thank you, Peter.
Okay. Questions for Toby. The first question is, would you consider fallout from HVAC onto surfaces as a concern? And the second question is, what is the risk associated with opening windows? What are your considerations? When should you open windows and when should you keep them closed?
I didn't hear the first question from you. I'm going to go directly on to the second question, and then you can just repeat the first question for me after. I would open windows, always. But again, as I said, the risks associated with open windows are really ones of safety. So don't open windows where there's a risk of someone falling out of a window or jumping out of a window. Also, perhaps consider external risks. So if you can't open a window because the safety of the people inside the building might be compromised, you might need to consider first addressing those safety concerns before you open the windows. That's all. So the risks around opening windows don't relate directly to COVID. They are the external safety issues. Peter, what was the first question?
The first question is, would you consider fallout from HVAC onto surfaces as a concern? And I have a related question, which is, would you consider the risks, say, for example, if you're going to be cleaning filters, to be greater than the sorts of precautions that you would normally take?
I'm not sure what is meant by fallout from the ventilation system. If you've got lint and dust and things falling, I'm assuming, if you've got lint and dust and those sort of things falling out from your ventilation system, you should just be cleaning that. It's, as I said, there's no evidence of viable coronavirus surviving in a ventilation system. No COVID-19, to my knowledge, has been cultured from fans and ducting. The virus is found, but it's not viable. So the risk is low. Again, don't take any risks. Don't avoid cleaning these systems. Just wear gloves, wear masks, and observe proper personal protection and hygiene. So the risk is very low. Just take appropriate precautions.
Okay, thank you, Toby. We don't seem to have any more questions. So I would like maybe to have a quick discussion about resources. Professor Douze mentioned that the landscape of resources is changing rapidly. And sometimes it's a bit overwhelming. There's a lot of information out there, and it can be a little bit overwhelming to know who to trust or what resources are. So we have got a website, a wiki, which we've put, where we list repository, a national repository of resources. We will try to keep that current. It's showing, I think.
Peter, we do not hear you. We may have some network problems, but let me continue. And Peter, please come in if you believe the network is up and running again. So we have a list of reading documents available.
Hello?
Yes,
I lost contact mid-sentence.
please go ahead, Peter. We have now on the project the list of reading documents available. If you and you also said that you have a website where you continuously update the newest documents.
Thank you. Sorry about that. Okay. So what I've done from this list is we've highlighted the ones which we think will be of interest to this audience. And you can see that there are an enormous number of resources available. For example, there are cleaning guidelines for workplaces, and that was mentioned in the first presentation as well. There are occupational health and safety directives, which are gazetted. There's a lot of guidance on vulnerable employees, on workplace preparedness. There are risk assessment tools available, and so on. So on the last slide, you can see the wiki link, and we will endeavor to keep those current. Maybe in due course we'll be able to annotate those a little bit and to provide guidance on how relevant they remain at any given time. But we are hoping that we can kind of get on top of this and provide a role doing that. I think that's now to turn back to Marti to close for the day.
Thank you, Peter. And the last slide from all the reading materials is, as all the other presenters did say, this is constantly evolving field. But for me now to end this is to say thank you very much first to my co-host Peter de Jager for following the chat box and leading the question and answer session. And then also to the presenters. This really has been very, very informative, and I trust all the participants enjoyed it as I have enjoyed it. This first webinar showed that we know a lot about pathogens. It's not something new, and not new, but we've learned a lot from other pathogens. And we have in our power the knowledge as well as the resources to be able to control this epidemic and this pandemic. But also that much of what we need to do is common sense, how to protect ourselves, our co-worker or the person next to you, and then also in terms of how and what we need to do in terms of the office environment, in terms of ventilation, heating, and controlling the airflow. So I would like all of you to attend the next webinar that we will have on next week, Tuesday, 7 July, the same time, from 11 to 12:30, and there we will drill down more into the complete details of how to safeguard the office risk assessment and cleaning of the surfaces. So thank you again from my side, and we are looking forward to have all of you again participate next week. And please keep on sending us your questions and answers also next week. Thank you very much.
Thank you, everybody, and hopefully meet you at the next one.